Hi everyone, welcome to Webinar Wednesday. Most of you that come to this know the drill by now, but for those of you new, I'm Carly Endries. I'm our outreach coordinator for North Dakota Brain Injury Network. We are excited to have Toby with ABA Consultants with us today, but I just wanted to mention a couple things before we get started. We will be having another Web Wednesday, July 28th, and that one's kind of on budgeting because I know when a lot of our individuals sustain a brain injury, their bills that begin to pile up. So I thought it'd be a good topic to just kind of talk about some budgeting things. And then August 11th, we have a More Than My Brain Injury. And September 8th, we have another survivor that's going to do Rise Above Conquering Adversity. So we have quite a few coming up. So continue to join us, please. So where you found the link for this, you will also find the recording after this is done, and you will find a link to a CEU request. You just fill that out and that comes to me, and I will get you your CEUs within a couple days after that. So I think that's about all my housekeeping. But Toby and I worked together many moons ago at Red River High School. She was a paraeducator in the autism classroom, and she always did an amazing job with those students, and then went on to found this company, ABA Consultants. And so I invited her to talk about behavior and ABA therapy in general, and just how that might look in relation to brain injury. So you can take it away, Toby. Thank you.
Okay, thank you. So I'm Toby Trontvet. I'm a board certified behavior analyst, licensed behavior analyst in the state of North Dakota. And I'm going to talk about applied behavior analysis as a science, and then how it relates to individual populations, and then some research with ABA and brain injuries. So the first thing we'll talk about is what is applied behavior analysis. So it is a science that we scientists, behavior analysts, use evidence-based methods to teach and improve socially significant behavior. It's all based on the motivation of the client that we serve, and it should only be used on socially significant behaviors for that client. My main population that I work with is children, so there's a lot of stakeholders in that. If I'm working in an education system, we have teachers, admin, or parents, if we're doing in-home, that might want us to focus on a certain behavior. But our job as behavior analysts is to make sure the behavior we're focusing on is socially significant for the child or for the client that we are with. People use behavior analysis every day, all the time. They just don't know that that's what it's called. So if you've ever learned a new skill step by step, that's a chaining procedure. It's behavior analysis. Your behavior at stoplights, if you know to stop at red and go at green, that's behavior analysis at work. Finishing the dishes before you watch TV or scroll social media is also behavior analysis. So first we'll touch on the 5 basic principles to aid in understanding behavior, which is reinforcement, punishment, extinction, motivation, and stimulus control. When we look at reinforcement and punishment, reinforcement is anything that increases a behavior or maintains its level. Punishment is anything that decreases. So in behavior analysis, punishment isn't bad, and reinforcement isn't necessarily good. They're just neutral. It either just raises or increases a behavior or decreases behavior. And then we have positive or negative reinforcement or punishment. And that positive, you're adding a stimulus; negative, you're removing a stimulus. So positive reinforcement, you're adding a pleasant stimulus to increase and maintain behavior. So that might be if you complete the dishes, you get to watch TV, or if you complete the dishes, you get $5, or whatever the reinforcement is for the person. Positive punishment then would be adding an aversive stimulus to decrease a behavior. So you might think of when cats are doing something that they're not supposed to be, people squirt water at them. That's adding something that's aversive to decrease the behavior of cats scratching the couch or whatever it might be. Negative reinforcement is we're removing an aversive stimulus to increase or maintain behavior. So if you have a headache and you take ibuprofen, that removes the headache. So your behavior of taking ibuprofen will probably increase in the future if you have a headache. Negative punishment is removing a pleasant stimulus to decrease behavior. So this looks like taking away an iPad from a child if they didn't clean their room or whatever it might be, again, that's motivating or unpleasant for the person themselves. Positive reinforcement and negative reinforcement get mixed up a lot. It's easy to do. They can be kind of confusing. So again, I work with kids, so a lot of my stuff is going to be child-based. Just try to think of it in terms of adults or yourself to help it make a little more sense. But you've got homework, you get ice cream after you do it, you're adding something positive to increase the homework behavior. Negative reinforcement, you did your homework, so now you don't have to do the dishes. You get out of doing something aversive by increasing a behavior. So we have 4 functions of behavior. There's 4 reasons behavior occurs. And the most important thing to remember is all behavior is communication. The behavior is communicating something. And so that's what we have to look at as behavior analysts. And the first thing that we can talk about is attention. Behaviors continue to occur, increase, because they're being reinforced by attention. This is either from adults or children or peers, and it, again, doesn't mean good or bad. So in child world, in the academic setting, a lot of people think that kids who get told no or told to stop doing something would be a punishment, but if it's an attention maintained behavior, they're still receiving some form of attention, therefore behavior is going to maintain or increase. Escape avoidance is the next one we'll talk about. A behavior continues to occur or increases because the person is escaping or avoiding something. That can be a task, a person, a setting, an environment, a feeling or emotion. All of those fall under escape avoidance. This is probably what we see the most in the behavior analytic field, is we all are kind of automatically set up to try to escape avoid things that we don't like. And so this is something that we all do probably a couple times a day. The next one we'll talk about is access to tangible. Behaviors continue to occur or increase because they're reinforced by gaining access to something. So this looks like gaining access to an iPad, gaining access to maybe a specific environment, gaining access to food, all are tangible things. And then the last one we'll talk about is automatic and sensory. So behaviors continue to occur or increase because they're being automatically reinforced. We think of automatic reinforcement as looks good, smells good, tastes good, feels good. So any of your behaviors that you do kind of repeatedly, some people hum, some people blow bubbles with their gum or snap their gum in their mouth. Some people move their foot when they sit. Those are all automatic behaviors. You're doing it because in some way, shape, or form, your body likes it. That also means it doesn't necessarily always have to be a good feeling. If you've ever had a toothache and you play with that tooth with your tongue, it doesn't necessarily feel good, but your body needs sensory input, and that's one way that your body gets that input. So how do we know what the function is? We use something called an ABC data sheet. We look at something, oh, I see my slide for the after moved in the wrong spot, but the A is for antecedent, whatever happens right before the behavior. You walk into a room and it's noisy, the behavior is you turn around and leave. The consequence is you escaped being in the noisy environment. So consequence is whatever happens immediately after. Again, in our language, I think we usually see consequence as something that's negative, but in behavior analysis, consequence is just whatever follows the behavior. It can be good, it can be bad, it can be neutral. It's just whatever follows the behavior. So ABC, antecedent, behavior, consequence. The next thing that we look at when we're thinking about behavior is the motivating operations. So this is something that either increases or decreases the reinforcement of something, the level of reinforcement that you get. So in the picture here, it talks about how the occurrence or non-occurrence of doing laundry is entirely contingent upon the amount of underwear that are clean. Another way to think about this is if you're really hungry and you drive by McDonald's, going into McDonald's is much more reinforcing when you're hungry. However, if it's right after Thanksgiving, you've had a big meal, you're no longer hungry, therefore McDonald's isn't as reinforcing. So that's what we look at for motivating operators, is we need to make sure that whoever we're working with, if they're getting too much of something, they're getting satiated with it, which means our reinforcer is not going to work. And if they haven't had it for a long time, our reinforcer is probably going to be more powerful. The other thing we have to think about is setting events. Setting events happen before any antecedent or trigger, and these are things like being tired, being hungry, medication changes, being ill, all things that don't make a behavior necessarily happen, but they might increase the chance of a behavior happening. So one example that I can think of a student that I have worked with, they would bite themselves, and the chance of them biting themselves when a task was presented increased more if they were tired than if they weren't tired. So the presentation of task every now and then elicited the bite on the hand, but it always occurred more if the setting event of being tired was there. So why do behaviors continue to happen? Behaviors only happen because they're reinforced. Behavior goes where reinforcement flows. If behavior is continuing, there's a reinforcement for it. So what happens when we stop reinforcing a behavior? We might get something called an extinction burst. As behavior analysts, we really try to make sure that this doesn't happen by manipulating the environment enough to try to not have an extinction burst. But in the reality, this definitely will happen, especially if a behavior has been reinforced for a very long time. So if you think of a vending machine, when you put money into a vending machine, you press the number. If you don't get the product that you had put your money in for and press the number for, what do? You press the number again, then you press other numbers, then you go back to the coin or return. You might even shake the machine a little bit. You have now escalated your behavior because your original behavior of just punching in the number one time didn't get reinforced like it has in the past. So extinction bursts are something that we probably all do, and is something you can all think of maybe doing yourself. I am definitely someone, if I've been at a vending machine and didn't get reinforced, have pressed several numbers again. And so it all depends on your level of learned history with something. So what do we want to do? We want to replace that negative behavior or the behavior that might not be socially appropriate with a behavior that is. So we're replacing that kind of unwanted behavior. Again, that means we have to reinforce the socially appropriate behavior, socially significant behavior, whatever it was that the client wanted. And it needs to be at an equal duration and intensity. Another example I have is there was a student that would strip down and run through the school, and this behavior occurred more when the principal was around. And what the team had decided to do in that specific case is the principal would come in. If the student was clothed and doing what they were supposed to do, she would say, "On your mark, get set, go," and she would chase the student around the school while the student was fully clothed. So our first goal, let's not have the student strip anymore. And so we had to do that. If we had just had if the principal had just come in that situation and said, "Hey, how's it going, buddy? Way to go," it wouldn't have been at the same intensity. So the team would have seen that behavior continue. And then the other part of that is making sure that if that student did strip and run, that the principal couldn't be a part of getting the student back to where they needed to be, since she was the big reinforcement. So then we do something called fading, which I think I talk about in another slide here, but then that's just reducing that intensity and the duration so that the person doesn't need that big amount of reinforcement to continue that behavior. So something that we do with any new client is doing a preference assessment and pairing. A preference assessment is really finding out what the person likes. We work with a lot of students or people, depending on what area you work in, that might not have verbal communication skills. So we still have to figure out a way to know what they really want instead of other people just telling us what they like. Because even though we might think something's reinforcing, a preference assessment might show us that that person just relates that item to someone and that it's not actually reinforcing for that person. They just pick it as a way to try to communicate with the person that always seems to be offering that item. So we want to make sure that we really know what's reinforcing for a client. The next thing we do is pair with them. You're much more likely to follow directions and want to engage with someone if you like them and have built a rapport with them versus just coming in and telling someone what to do. I know that I would not work well under that situation if someone just came in that I didn't know and started giving me orders. And so we want to make sure that we're really building a rapport and getting to know the client and making sure that we're doing the best for them and the things that they want. The next thing we'll talk about is the PreMAC Principle. So the PreMAC Principle is a person's more likely to engage in a non-preferred behavior if they know that doing so will get them something preferred. I don't know many people that want to do dishes. I am not someone that wants to do dishes, but during the times that they have to be done, I'm going to reward myself with something at the end, whether that's watching my show, scrolling social media, which is something I seem to waste a lot of time doing, going for a walk with my kids, maybe having a special treat for myself, whatever it might be. I'm going to reward myself for doing something I don't want to do because then I'm more likely to do it. Another really important thing in behavior analysis is something called shaping. So we want to reinforce successive approximations toward a target behavior. Again, with people who can't verbally communicate or can maybe say some sounds and they're working on expanding that repertoire, we would then reinforce just slight approximations. So if we're trying to get a child to say iPad and they make the I sound, that's the first thing we reinforce. Great job. That was a successive approximation towards the full word. If we have a student that's using picture cards, a successive approximation would be even just looking at that card over other cards that were available, and then hopefully getting them to touch the card, and then next getting them to hand the card to someone to request. So we shape all sorts of different behaviors. The main thing that I think a lot of behavior analysts probably worked on this past year was shaping mask wearing. Not a lot of people knew or wanted to wear masks all the time or correctly. And so we had a lot of shaping to do with students where first it was just touching the mask, then it was holding the mask up to their face and putting it down. Then it was having the mask on for 5 minutes and then being able to take it off to try to get them to a level where they could have the mask on and it wasn't bothersome to them. And then fading, which I had just touched on, is just making sure that if we're always reinforcing behavior at a really high level and we never fade it, then reinforcement is always expected at that same level. So then you're going to run into more behavior issues. So once you have success with someone changing their behavior to get the reinforcement, then you decrease the reinforcement. If you think of a slot machine, that's not reinforcing you every time. That's reinforcing you on a variable schedule. So that's what you would want to do for other behaviors as well. So now we can kind of touch on what I learned. Brain injury is not my area of competency. I work with, again, just children, and more so in the education setting. So I have students with a wide array of disabilities under that category, and some students that don't have a diagnosed disability that just may want some help with something, a little bit of change. So what I found in some of the research I was doing on brain injury is that there's a lot of children, infants and toddlers, who experience a brain injury that are either never diagnosed or it wasn't serious enough to warrant further treatment, so they thought. And what they're seeing is that these students or these children are coming in and they're being labeled or identified with a specific learning disability, an intellectual disability, an emotional disability, when that's not necessarily the case. What happened was they had experienced a brain injury. And school psychologists are expected at that point then to provide the educational treatment for a brain injury, but they aren't really taught a lot about brain injuries in school. So I found that interesting that we aren't, as a society, quite yet set up to really help kids in the setting that I specifically work in. So what behaviors can ABA help with in those that have experienced a brain injury? So the neuroplasticity, that's the avenue in which ABA can really be used in brain injury patients or people. So we're looking at behavioral challenges, social skills, impulsivity, aggression, noncompliance, finding those motivators. When a brain injury occurs, motivators that someone might have liked before might not be something they like anymore. And so we have to find something different. Anxiety, depression, addiction, and then rehabilitation of the self-care and the daily living skills. There was a comprehensive study conducted comparing various treatment modalities that found that significant motor function could be recovered with intensive behavioral rehabilitation. And then from what I learned as well is that social cues that patients or people that have experienced brain injury used to know might be lost. And so that's definitely where behavior analysis can come in and help retrain some of those pathways to hopefully get them to a point where they feel good. So what would treatment with ABA look like for those with brain injuries? So if we think about someone who can't speak maybe, and they have a trach tube and they're experiencing pain, they show us behaviors prior to aggression. Most people, almost everyone, will show a behavior prior to aggression. So in this example, the person might moan or squirm, cry, wince while they're in physical therapy, and they don't get to immediately escape whatever it is. The therapist might not be looking at them at that moment, whatever the reason they didn't pick up on those cues. And then the one day the person smacks the therapist, because that is one behavior that will almost always get you the motivate or the reinforcement you need, whether it's escape, attention, whatever it is in the case. And the next day the person winces and goes to swing, and the PT can respond at the wince and reinforce that as a signal to stop instead of reinforcing the aggression. So again, it goes back to all behaviors communication. With ABA, that's what we look at. We look at what is occurring, what are the behaviors of that person prior to the behavior of concern, that we can start to reinforce those and then teach the replacement behavior at that spot. With brain injuries, it's very important for behavior analysts to work with the entire medical team so that we know what is a behavior because of a reduced function, and then what is a behavior due to a specific injury in a specific part of the brain that we would have to look at in a different way. In the beginning, a lot of the behavior analyst work would be conducting just a functional behavior assessment and doing a lot of observation. And then once more treatment is going on, then we could really have the behavior analyst be more hands-on. And then after a behavior analyst is involved, they write something called a behavior intervention plan, or a BIP. And what that looks like is it has everything written out on what to do and how to do it, so that any person that's part of the medical team, or any caregivers for that person or that person themselves, all know what steps are supposed to be done in what order to help increase the replacement behaviors. So for some clients with traumatic brain injury or acquired brain injury, we have to look at if memory and cognition are impacted. And if that's the case, we might have to start at very extreme basics, which is completely fine. It's something that we're very used to doing. And then it helps us build to bigger skills. Stimulus control is something where you're creating associations between that positive reinforcement and the desired behavior. So that's that once you do the dishes, you get to have a cookie. That's creating that stimulus that once dishes are done, reinforcement occurs. Chaining, that's a series of stimulus responses used to shape more complex behaviors. Everyone has participated in some form of training. Chaining, if you think about making a peanut butter and jelly sandwich, that's a chaining procedure. Washing your hands, that's a chaining procedure. You might have someone who can only turn on the water, and then you have to prompt them through the rest. And then next, they turn on the water and you give a prompt to get some soap, and then go from there until they have the whole procedure that they can do independently. And then response practice. So that's practicing responses repeatedly. That might be flashcard practice. That might also be going out, and if the goal is to be able to purchase something independently from a gas station, that's exchanging money repeatedly to understand that concept again and kind of do some rewiring if necessary. Some interesting facts that I found was the military is experimenting with combining ABA and CBT, cognitive behavior therapy, for treating problematic behaviors with interactive I'm going to try that again. The military is experimenting with combining ABA and CBT on soldiers that have experienced brain injury. And that in one of the case studies that I read, just with the stimulus equivalence control, there were 3 patients that regularly recalled the names of their therapist upon seeing their faces, which is something that they hadn't been able to do through the course of many prior rehabilitation techniques. So antecedent strategies, if we think back to the ABC part of finding the function of behavior, antecedent strategies are probably the most important, because we want to prevent behavior from occurring, and we want success in using the replacement behavior. So we want to set up an environment that's not going to trigger a behavior to occur, that we can work through that replacement behavior. So we probably have all been in a situation where we go into an environment and we're overstimulated for whatever reason. It could be the sounds, the lights, the smells, the tastes, the touches, whatever it might be, where we want to escape. ABA can use several different techniques. We can do a little bit of exposure. So we start out with maybe a faint scent of an aroma and then increase it to what might be considered an average level of whatever the scent is. We can do environmental changes, working on functional communication, where people can just say, this is too much for me, instead of having to use a maladaptive behavior to communicate that. Visual cues, verbal cues, checklists, pre-teaching. If we're going to do something out in the community, we will pre-teach it so that the person feels prepared and ready for whatever might come. And antecedent strategies are the easiest to implement. They're the easiest for caregivers to implement. They are usually the least cost and are just something that everyone can do successfully. So this is more just so for implementers when we're looking at things, the reducing of sounds, lights, temperature, being aware of our own nonverbal communication, facial expressions, tone of voice. Sometimes when we request someone to do something, if we do so in a tone that comes off more aggressive, we're less likely to have someone comply. Where if our tone is positive or neutral, they're more likely to do what we're asking because it doesn't seem threatening. Same with facial expressions. You want to make sure that if someone does something that was unexpected, that maybe you're not reacting to it, because we don't want to reinforce an inappropriate behavior or a socially hindering behavior, but we also don't want to have anyone feel embarrassed or concerned about something that they might have done as well. We want to make sure that we're calm, confident, and then the most important part of a behavior plan is it needs to be structured and it needs to be consistent. If it's not consistent, it's not going to work. And one of the most important things is offering choice. So a lot of people will ask questions. Are you ready to get in your shower? Are you ready to do your dishes? That gives the option of no. And that is a valid response and needs to be respected. Instead, though, stating a choice is going to be more beneficial. Do you want to use your washcloth or a loofah in the shower? Do you want to shower now or do you want to shower in 5 minutes? So it's not necessarily allowing the escape behavior to occur, but the person is still in control. So then we have checking the social validity and efficacy of an intervention. With behavior analysis, we always want to do ongoing evaluations, making sure that if we're meeting goals, that we're having new goals, or that we're ready to say that someone doesn't need behavior analysis anymore, which is the ultimate goal. If something's too difficult, we want to make sure we're checking in on that so we can scale it back a little bit, break down activities into smaller steps, shorten duration if that's the case. If something's very difficult, the next thing we're going to ask someone to do is going to be easy. We don't want to just overload someone with things that are hard. No one wants that. And then making sure that there's breaks that are occurring often. The gradually increasing changing performance criteria, that's changing the goals up, and then establishing those good replacement behaviors and reinforcing those. So then we look at consequence kind of strategies that can occur, that you can do. When we look at consequence stimuli variables, we have to remember, especially with brain injury patients, that previously learned behavior reinforcer relationships are impaired. So what that person might have known prior to an injury might no longer be something that they know. And so that has to be retaught, not expecting that someone would just know specific societal rules or expectations. And that effects of rules may be altered, and changes in the current behavior reinforcer relationships are going to probably be needed and retaught. Quick responses to requests are really important. So once you see that replacement behavior occur, especially with any form of communication, making sure that you're responding quickly and appropriately and getting that reinforcement available right away. Making sure that the person is included in all goal making and decisions, looking for replacement behaviors in any form or frequency so you can provide those reinforcers, maximizing positive to negative statement ratios. As a society, we are really quick to say no doing this, don't do that, don't do this. And so it's very negative, where what we're saying is increase the positive. So, wow, great job sitting. I love how you took your notebook out of your backpack. Now I need you to find your pencil. So the negative is gone. We're reinforcing the steps to the behavior we want. Now we need Johnny to take out his pencil to be able to start class. Again, flip that into adult world. And then the consideration of the reinforcement delivery and making adjustments, that fading that we talked about, that decreasing reinforcement or giving it every other time, changing up the amount of reinforcement that's given. So where can ABA be used? Anywhere. Environmental modifications are definitely needed for a lot of people with brain injuries, and then just a lot of people in general who are using behavior analysis. And that means that behavior analysts go into hospitals, rehab facilities, private care clinics, the educational setting, long-term care facilities, and homes. My company specifically, we go into children's homes to conduct ABA services, which also means that we also go out into the community with our clients if that's goals that we're working on. And now we can get into some of the research I found. So this is behavioral treatment for pathological gambling in persons with acquired brain injuries. This was an 8-week program at Southern Illinois University. One of the authors here, Mark Dixon, actually has a fantastic program that he had set up at Southern Illinois for gambling addiction specifically. And so he had a ton of research leading up to this with people that did not have a brain injury. And so this is a study that they did to see how the same setup would work for people that had a brain injury. There were 3 adults that were between the ages of 31 and 49. They all had an acquired brain injury and were residing in a medical or behavioral intensive setting. And then they were all identified as pathological gamblers by a SOGS screen. So during this study, they were given money, and then they had 15-minute sessions, and they could use the money. 2 of the participants played blackjack, and 1 participant bought lotto tickets. And so 1 ticket or 1 chip was $1. The treatment was then followed by an hour, the gambling was then followed by 1 hour of CBT that identified the antecedents to the gambling, the alternative reinforcing activities, problem solving, assertiveness training for when people were asked to gamble with their friends or go into a casino, go into the gas station, and then dealing with relapses and some long range life planning. And after treatment, generalization procedures were conducted. So they actually took these participants into casinos or to a convenience store. And what they found was that participants decreased the money that they spent gambling during treatment, and then continued to decrease even more when generalization procedures were implemented at the casinos and stores. So in the generalized portion of it, when they actually went to the casino or the convenience store, they were given money from the researchers, and then they were also allowed to bring as much money as they wanted of their own. And they found that several times during the generalized procedure, people didn't spend any of their money gambling. So it was a very interesting study. Another study that was done was with 3 patients in a comatose vegetative state for 6 months, 10 months, or 38 months. Patient 1 was in a rehab facility, and then the other 2 were in nursing homes. And 3 responses that would be reinforced with music were chosen by the rehabilitation team. So for patient 1, it was moving their fingers, mouth, or eyelids. And then patient 2 and 3, it was eye focus, lateral head movement, and mouth opening. These were all behaviors that the team had seen the patients do, but not on command. So they knew that their body had the ability to do it. It was in their repertoire. It just wasn't done on command. And for a response to occur, it had to be within 10 seconds of the trainer's verbal request. And then they would receive 15 seconds of music that was chosen by their loved ones. So it was music that was reinforcing to them prior to the injury. And what they found was that emission rates of behavior rose in all 3 patients in the music contingent phase. For patient 2 and 3, only 2 behaviors seemed to be moderately affected. The 3rd behavior, which was mouth opening, was not affected. And at the time, patient 1 with the move fingers, mouth, and eyelids, the researchers were told that the left hand did not have the ability to move, so researchers didn't have to observe it. And what they found after treatment is that the movement of the left hand started to twitch during the music contingent phases, and the left hand changed so radically during this whole experiment that the patient actually became a management problem due to using the left hand to pull out his gastrostomy tube. So that was something that was unexpected and very great. They obviously reinforced every twitch of the left hand, which reinforced some more movement in the left hand that they were told wasn't functioning. For patient 2, eye focus, the goal was for 2 seconds, and there were several occurrences that patient 2 focused on the experimenter for 10 seconds, which was something that had never been done in the 10 months that the person was considered in a vegetative state. Patient 1 did eventually recover from the vegetative state, but with severe impairments. Patient 2 never recovered. And then patient 3 ended up passing away due to hypertension about a week after the experiment. Another thing, using choice to increase on-task behavior. There were 3 participants in this one as well. Tasks were chosen based on deficits in self-care skills observed in previous sessions. So they were working with the occupational therapist and the physical therapist to know what tasks were already being treated and what they were working on in their own domains, and then how they could help. And then each session or each self-care skill would take 10 to 15 minutes. So they had a choice condition, a task assigned, should say condition, and then a yoked control condition where the tasks assigned were the ones that the patients had already previously chosen. So they knew that it was what they had wanted. And what they found is that on-task behavior increased during the choice phase, and that participants were still less likely to engage in the yoke phase where they were told to do what they had already picked. So giving choice showed to be something very important and something that would help maintain on-task ability. And then the last thing, I had mentioned Mark Dixon earlier in the gambling study. He has also created a curriculum that we are rolling out now in the Grand Forks Public Schools, and it incorporates mindfulness, ACT, and ABA. So ACT, acceptance and commitment therapy, combines mindfulness and ABA. It's based on relational frame theory. F and T should be flipped on that. And how humans learn to relate to the world. So it increases the adaptable, flexible responding to get reinforcers. It can be kind of confusing, but it's essentially, the main premise is figure out what's most reinforcing in your life and do behaviors to get you to that versus behaviors that are going to get you away from what you find reinforcing. Maintaining being in the present moment, and then just how we interact with kind of stimuli in the world or language in the world around us. ACT has been shown to help all sorts of people with all varying disabilities or concerns. It actually helps decrease seizure activity. In some studies, it ACT is very interesting if you ever have the want to learn more about acceptance commitment therapy. It's very neat. And so AIM is a curriculum. It is geared more towards kids, but having to learn it myself and teach others how to use it, it is incredibly useful for adults. It's very interesting. I was not a big mindfulness person, but these studies on mindfulness are very intriguing. The research on it is substantial at this point and has a lot of evidence-based effects that are very neat. And then one study that I found, people that had a brain injury reported improvement of quality of life with 12 weeks of mindfulness training. So something to think about if mindfulness is a little difficult sometimes, especially if you're someone who is not a big mindfulness person or has never really gotten on board. But once I saw the scientific evidence behind it, I thought, wow, this is probably something I should be doing in my life. And that's the end.
Awesome. Thank you, Toby. I have a couple questions if that's okay with you.
Absolutely.
Okay. Okay, so we get this one a lot, or we kind of struggle with this ourselves. So how do we gauge whether behavior is the result of like a deficit or if it's a choice they're making? How do you gauge that? Like their comprehension of what you're asking them to do?
Sure.
Is that making sense?
Yeah. So the first thing would be that finding kind of the ABC, what is the function of that behavior? What is it getting them?
Okay.
With the research that I had done on brain injury, again, not my area of competency, so I hope I don't
No,
say
you did great. Yeah, no.
correct.
Yeah.
But with brain injury, there's some behaviors that might occur due to where the brain was injured and not necessarily because it's a choice or
Sure.
So number one, obviously working with the medical team, making sure that we know that there is some form of way that we can teach a different skill, or that we can look at what that reinforcer is and that it's not just a movement for whatever reason that the brain is doing. And so finding the function is basically number one. And if you find the function and stop reinforcing that behavior while teaching a replacement behavior, they have to happen at the same time, and you see behavior change, then you know that it was a way that they got what they needed with the least amount of effort.
Okay. Thanks. What are your thoughts on using food for like reinforcement or food or pop or soda? That's kind of a common thing, and it's.
I do. I personally would not be okay with it. Those are basic needs. If the person consented to using that as a reinforcer and said, I know that I shouldn't have Skittles every day, so that's what I would like to work for, then by all means, the client has consented to it. They have picked the reinforcer, but it's not something that I would suggest to do without client consent.
Okay, good. What about, do you have a certain like preference assessment you use, or I suppose you use a different one depending on the skill, the level of the person?
Yeah. So in kid world, we use the ABLES a lot, which identifies a whole range of skills with fine motor, gross motor, communication, basic life skills. For adults, I know that there are some really good life skill assessments. I don't know what all they are. I could
That's
probably
okay. I
find
don't
you.
expect you to. I was just
Okay.
curious if you had like a favorite that you, yeah, but okay.
Yeah.
Then tell me about your services. Like how would I plug yourself a little bit. Tell us like if I wanted to call you and have you come out, what would that look like? Or yeah, tell me about,
Sure.
yeah.
So unfortunately, in the state of North Dakota and pretty much the country, ABA services are only paid for if there is an autism diagnosis.
Okay.
So, and usually if the person is under the age of 21.
Okay.
So if you're looking to use insurance, that's pretty much the only way that insurance is going to cover it.
Okay.
Otherwise, contacting us and asking for a consult, and then we could discuss if whatever it is they're looking for is within our competencies, and then going and doing the functional behavior assessment, finding the functions of the behavior, and then moving from there. But then it would be out of pocket.
Right. Sure.
And
So you
some,
kind of, talk to them first. If it's going to work, then you come out
yeah,
and observe, and then kind of, is there like an average length of time that you see a client, or is it kind of vary depending on all of the factors, I suppose?
varied depending on if we're working on one specific behavior. So let's say we're working on skills to self-care skills.
Okay.
That's going to take less time than if we were working on self-care skills, academic skills, certain behaviors,
Right.
etc.
Sure. Lots of things. Yeah.
Yeah. So it all depends. If we come in for one specific behavior, it takes a lot less time than if we were looking at a large range of skills.
Okay. Okay. And are you just in Grand Forks here, or this Grand Forks area, or how far is your reach?
So currently we are just in Grand Forks.
Okay.
At one point we did reach further, but the world became crazy
Yeah, well, we get that. Yeah.
like a year ago. A year ago now when COVID hit. And
Yeah.
so right now we are maintaining just the Grand Forks area.
Okay. Okay. Great. So her email is down below if you have more questions. That's all of mine. But thank you so much. That was great information. Yeah, very good.
Great.
There we go.